In this lecture, we're going to cover care of the postpartum patient. All right, so as an overview here, postpartum, and I put this word in here, although most of us don't use this word, but this word right here, you might see out in the field, you might see on your boards, so I really want to make sure that you do know what this word is, but it means the same thing as the postpartum period. And what this is the period of time between the time that the baby and the placenta are born and the time that the body goes back to its pre-pregnant state. Typically, it takes about 6 to 8 weeks, depending on any complications of delivery or anything like that. Our greatest risk during this period, as it outlined here, is hemorrhage, shock, and infection, with our goal being to prevent a postpartum hemorrhage. All right, the first part of this content is divided by systems. So the first system we're going to talk about, or the first body part, if you will, we're going to talk about is the uterus. Now, remember, up until right now, this uterus, this big muscle that we were talking about, has had a baby in it. So inside this big muscle was a fetus, a placenta, and amniotic fluid, right? So it's nice, big, outstretched muscle. And now all of a sudden, the patient's not pregnant anymore. So we need to make sure that the uterus is trying to return to its pre-pregnant state. And what the term for that is involution. So what involution is the return of that big muscle to its non-pregnant state. And how it does that is through contractions. Now, these are not the big contractions your patient's going to experience during labor. You still have to contract the muscle to make it go smaller again, but they're not going to be these big whopping labor contractions that this person went through already. So how we go through here, and then if you're looking at this little grid right here on the bottom. So as soon as the baby and everything is out at delivery, typically the fundus, which as you know is the top of the uterus, can be found right at the umbilicus. And there can be a little, nobody is a robot, right? So there can be some variances above or below a little bit. But when you're going to go and assess somebody's fundus and it's been the first, like right after delivery, your landmark should be the umbilicus. Start there, all right? And it should be firm like the table, and it should be midline. If it's not firm, the opposite of firm is boggy, and that's concerning. And then the opposite of a midline fundus is displaced fundus to the left or the right. And typically that happens because there's fragments of placenta or membranes in the uterus, or somebody's bladder is full. So like I said, on a normal situation, your patient immediately after delivery should have the fundus firm and at the midline at the umbilicus. So that's our goal. All right. Anything off of that, you should keep investigating. And then you'll see here that it says that every day or so, the fundus is going to descend lower into the pelvis about 1 to 2 centimeters every day. Now, some old school nurses and some textbooks might still call, instead of saying centimeters, they say finger breadths, but most of us can't say that. So, but I do, again, I put that there in case you're seeing that, you know that it's used in the same way. So typically by the time your patient is 2 weeks postpartum, and again, they're at home by that point, if they wanted to palpate their fundus, they couldn't. It's too far low into the pelvis. Now, again, here's this picture, right? So your patients, and so if somebody is stable, without complications, they go home 2 to 3 days from delivery. All right. And so think about your assessments here, right? This picture here on the bottom goes way down here. Well, this person's going to be home by then. Okay. So just that should kind of help you with the landmarks. So we should be able to achieve complete involution by 6 weeks postpartum, which makes sense because that's the end of your postpartum period. So how your uterus contracts, I'm going to start again. So involution is facilitated through the release of oxytocin. Now, people can have oxytocin going through their IV. You can have oxytocin being given as an injectable, intramuscular. Or if the person's going to breastfeed, by breastfeeding, our body releases oxytocin in our own body, and all of the oxytocin makes the uterus contract. So the contracting uterus is what facilitates the involution. So you can expect your patient to be on some kind of Pitocin in the recovery period of this. It's really important that we make sure that we assess fundal height certainly as soon as we receive our patient into the postpartum unit, of course. And then if they're stable, you're going to reassess it 8 hours later. And we're going to talk about our focus assessment in just a little minute. If your patient is not stable, then you're not going to wait 8 hours to assess the fundus. Okay, so we're still talking about the uterus here. The uterus has a big job because remember, your patient, like I said, was just very recently pregnant. So now we got to make sure that the uterus is contracting so we can get the involution process happening here. So the next piece about the uterus we're going to talk about is this word here called lochia. This is actually, I just wrote right over that. This is actually pronounced like a K, even though it's the CH, but it's pronounced lochia. So what lochia is the discharge. It's vaginal discharge, and it looks like blood. Most people say it looks like blood, and it does because it's red, but it also contains some mucus and some uterine tissue too. What I want you to think about is where that placenta was residing on the side of the uterus, which now the placenta is delivered, so we no longer have that inside of our body. The lochia is coming from that site. So as the site heals up, we have less discharge, less lochia happening as well. There are 3 different stages of lochia, right? So we're going to talk about all 3 of them. We have lochia rubra, that's one. Lochia serosa, that's another. And lochia alba is the finest one. You can see that the farther we get from delivery, we kind of go down these different stages like this. So let's talk about the first one. This is the one that you guys are going to see with your patient in the hospital. This typically lasts 1 to 3 days. And like I said, by the 3rd day, your patient usually is going home. So a lochia rubra is the one that you guys are going to see. It's the one that people talk about where they have a heavy quote period. It is not uncommon for the lochia rubra stage to have small clots in it. Now I'm going to use things that are descriptors for you so it can make sense to you. I kind of look at things like a dime size clot. You know how big a dime is, so that's pretty small. And then a quarter clot gets bigger, and like a $50 clot is bigger in the size of an orange. So people are visual. So when you're giving a report to people, you want to use descriptive words. So back to that, in the lochia rubra stage, it is not uncommon to have large to moderate amount of lochia rubra in the first, especially the first 12 hours, but also you can have small dime-sized clots. That's normal. And typically when your patient gets up or if they're breastfeeding, you're going to have the flow increase. Because again, if they've been kind of laying in a semi-phallus position or a low phallus position, the blood's just going to kind of drip from the placenta site in the uterus and kind of collect at the back of the uterus. And then when they stand up, they're going to have this dumping of blood. And that's normal. We as nurses are used to that, but it really kind of freaks out the patients. But that's normal. Now, if we have blood pouring out of our body and constantly trickling out of our body, or having passing of things that are bigger than a dime or maybe a nickel is probably the biggest that you can expect, you better let somebody know. There's usually a problem with the contractility of that muscle, so we got to look into that. So the next stage here is lochia serosa, which is, as you can see, it lasts from day 4 to day 10, right? So now these patients are at home. But what they can expect is when you get into this stage where you have lochia serosa, the vag bleeding is more of like a brownish color, okay? And it's going to be quite a bit less. Kind of backtracking on lochia rubra, it's not uncommon. The chucks, you've seen chucks in the hospital. We often will use those as peri pads in the first stage here, lochia rubra, because they really have a more of an increased amount of blood coming out. But as they go home and as they're going down through lochia serosa, they don't need these big pads anymore. They can use the pads that they can buy at the grocery store at that point. And then as we get into day 11 to 4 to 8 weeks from delivery, the discharge gets less and less and less the farther you out from delivery. This stage here, it's called lochia alba, and it's just like it says there. It's not really blood. It's more of like a yellowy color. One thing I do want to tell you, and you want to make sure you tell your patients this, if they're down here in these 2 stages here, and then all of a sudden their vag bleeding becomes more and heavy and with more clots, they're probably doing too much. So you want to tell them to kind of relax and not do as much. to listen to their body and to not lift, as a general rule, to not lift things heavier than their baby. Because again, having to watch their body and have them go through this recovery process here. The conversation in the literature right now is actually about making the postpartum period, that 6-week period, the fourth trimester, because your body goes through some spectacular changes from the time the baby and the placenta are delivered until the body goes back to its pre-pregnant state. So I guess the conversation is that if we can make it into, call it a fourth trimester, it will give it the credit that it needs to have for that. What I wanted to show you on this last piece on this slide talks about the desired blood loss. Okay, so this is what is normal. Now, if something more than that is going to lead us to have a conversation about a postpartum hemorrhage. So this is just a visual image of the different kinds of documentation that you're going to do when you're speaking about lochia flow. So this right here just came directly out of your book. So this just tells you in the first few hours after the person has their baby, we're going to do a fundal assessment as well as lochia assessment every 15 minutes after delivery, and then every hour, and then going up per the policy of the hospital. This down here, you see us measured here in centimeters. Nobody expects you guys to have a tape measure and measuring the amount of blood that's on someone's peri-pad. But this is kind of a picture to kind of help you understand what scant is versus light and moderate, okay? Right here at the bottom, your patients who've had a C-section typically have less lochia. So I know that some of you might not have seen a C-section or a vaginal delivery right now, but when someone's having a vaginal delivery, the baby comes out, the placenta comes out, and then the delivering person, so the healthcare provider, whether it's a doctor or whoever, will step in and do fundal massages and look and make sure the fundus is nice and firm. When somebody has a C-section, once the baby is out and the placenta is out, what the doctors will do at that point is take a lap sponge, which is kind of like a big piece of gauze, and they almost wrap it around their hand, and they kind of stick their hand in the uterus and do a sweep and get out all of the extra blood that is there, which you can't do that when somebody's had a vaginal delivery, right? So that's why clients who have had a C-section typically have less lochia than people who have had a vaginal delivery. So what are the things that should cause you to be concerned? I've already talked about the normal things in the postpartum period, but these are things that should cause you to stop and be concerned and further assess, right? So if your patient's having these things, you don't walk away and get some help. You don't leave your patients if you're concerned. So if your patient has experienced excessive spurting coming vaginally, typically that can indicate a vaginal tear or a cervical tear, something that was missed, but we shouldn't have anything aggressive happening, nothing spurting, nothing aggressive happening too. We already talked about the large clots and lots of blood loss, because the more clots you have and the more excessive blood loss that you're having, that means that the uterus is not contracting. A contracting uterus will push the lochia out, right? But if your uterus is very floppy or boggy, if you will, in your assessment, it's not contracting enough to get that blood to come out, and that's what you're going to notice and be concerned about. Foul odor, an infection, that one I think you would know. We already kind of talked about the clots. Let's talk about here, the bladder. Okay, I want you to think back to your anatomy class, okay? Now, I know it's probably been a minute, but if your bladder is full, it pushes everything around it out of the way. A full bladder is going to displace your uterus away off the midline. It's going to displace it to the left or displace it to the right, okay? So you want to make sure that your patient is emptying their bladder. I will say, if somebody has had an epidural in labor, the last thing to come back, once the epidural is turned off, of course, your sensation starts coming back. The last thing to come back is the sensation for the patient to feel like they have to pee. And I don't know why. So if your patient's had an epidural, make sure you're assessing their bladder often, because they may have to empty their bladder and go to the bathroom, but they may not feel the sensation because those nerves haven't quite been rejuvenated yet. Okay, so I want to tell you about what you can expect when you're seeing a vaginal delivery. Your healthcare provider is going to be at the bedside delivering the baby. So the baby's going to be delivered. The placenta will be delivered. And then as soon as the placenta is out, the massaging of the fundus should start. The fundus should be nice and firm, like I said, like a tabletop, and it should be midline. When somebody is rubbing on the fundus, so assessing the fundus, the blood the pushing on the fundus is going to make blood come out vaginally. But as soon as we stop pushing on the fundus, the blood should not be continually running out. Blood that continually runs out of any part of our body is indicative of a hemorrhage, right? So when you are massaging the fundus and you've taken the patient's underwear down so you can see the lochia coming out of the body when you're massaging the fundus, if you stop, the bleeding should stop for a second, okay? So again, if you're having constant bleeding coming out of the vaginal area or the vagina, that should be concerned that there's a tear or something else going on, okay? So we're still on the uterus. It has a big job, right? I mean, it pushed this baby out. So now we're going to talk about the contractions. I actually did this very intentionally. I could have put contractions, but I put something else that means the same thing. After pains are contractions, okay? So contractions, I already told you, contractions facilitate involution. That's what you can expect. That's normal. But contractions hurt, okay? So it's okay if your patient is uncomfortable. Let's get them some pain medication if they want it. A couple things about contractions or after pains. This bullet right here talks about how the contractions are increased with breastfeeding, because remember, breastfeeding stimulates oxytocin in our bodies, so that can cause pain. The more babies your patient has had, the more contractions they have in this recovery period. Now remember, let's think about that. That should make sense to you. The more kids you have, the more stretched out, the more oftentimes that uterine muscle has been stretched out. So let's say your patient has had one baby. It's only been stretched out one time, the uterus. But now in the other room, your patient's had 5 babies. So your patient's uterus has been stretched and gone back to its pre-pregnant state 5 different times, okay? So the more times that uterus is stretched to the max and tries to go back to normal, the more work it has to do to get back to normal, so the more contractions they're going to have. Same with multiples and fibroids. So with multiples, you have more kids, so the muscle's bigger. Same with fibroids. If you've got fibroids in there, that makes that muscle bigger. So anytime the muscle is bigger, that uterus, that muscle has more work to do to get back to its pre-pregnant state. Certainly, you can give somebody pain medication for the pain that they're having in this postpartum period. You will see on your MAR, most of our meds in this world are written by order sets. And so oftentimes your healthcare provider will check all different kinds of pain medication options. And your patient's going to call and just say, I need something for pain. And you're going to go in and do your assessment like you know how to do on a scale of 1 to 10 and go through that. And then based on your assessment, you, using your license, once you get it, can decide if you're going to do a narcotic for your patient or a anti-inflammatory type medication, a prostaglandin inhibitor, okay? So as you know, you can't take anti-inflammatory meds typically, like Motrins, those kinds of things, when you're pregnant, but you can take it in the postpartum period, and it is safe for breastfeeding, which is good. Okay, so let's move along. So let's talk about something else that people are always kind of curious about. Once they have their baby, when their menstruation or when their period starts again. And that's going to be different depending on how they're feeding their baby. If they opt not to breastfeed, they typically will ovulate, just like it says here, about 7 or 9 weeks after having the baby, and the period comes back at about 12 weeks postpartum. If they're choosing to breastfeed, it can take a little bit longer. Some people, when they're breastfeeding, never have a period. Now, you do ovulate when you're breastfeeding, but it does take a little bit longer, right, as you can see here. But it's important that a conversation needs to be had about contraception, okay? So that's a whole team conversation. But not everybody, remember, your patients may not be comfortable asking about it. So you may want to bring it up, or the healthcare provider can bring it up. But contraception certainly is an issue. Just because somebody is breastfeeding and not having their period doesn't mean they can't get pregnant. So we need to have that conversation. And if they do want to wait to get pregnant, we want to make sure that they can prevent their pregnancy. Okay, moving on to the cervix. We've covered what the uterus does. Now let's talk about the cervix. Now remember, what we're talking about here is somebody who's had a vaginal delivery. Somebody who's had a C-section, clearly there's no cervical or vaginal or perineal involvement. So the cervix, let's talk about that. Now, typically, we're not going to see the cervix, right? So, but if you did look at the cervix, you might notice that there's a little bit of bruising. It can be swollen. Okay, now remember, it kind of looks like a donut hole is the best way I could describe it. But I want you to remember what has happened to that cervix, right? That cervix went from being closed to having lots of vaginal exams done. So it's poked with people's fingers, and then it fully dilates, and then a human being comes through it. So there's been a lot of work that's happened with this cervix. So if you were to look at it, you might see this bruising, and that's normal. Sometimes you can have small lacerations. Small is what is the key word here. It's not normal to have large lacerations. The thing with the lacerations, though, even if small lacerations can be normal, anytime you have any kind of cervical lacerations, the issue with that is that the presence of cervical lacerations can delay the production of the mucus that comes from the cervix. And the thing is that if there's less mucus, we can have a bigger chance of becoming infected. So that's just something that we need to be aware of. And let's go on down to the vagina and the perineum. So down here at the bottom here. So when you guys have seen a delivery, and if you haven't seen one yet, don't worry, you're going to get to see one. But as the baby is coming out just in that moment, the perineum kind of becomes distended and a little bit elongated, but then it does go back to its pre-pregnant size, okay? Now, this sentence here, muscle tone is never completely restored. So I want you to stop and think about your prime gravida patients and your multips, right? You know that your prime gravida patients, their labor is longer because I've told you, because the muscles are tight and the ligaments are tight. And then the more kids you have, the looser those muscles are, and that's how come that those labors are shorter and the pushing is shorter. So that kind of goes hand in hand with this sentence right here, where it says muscle tone is never completely restored. Yes, your body goes back to its, quote, pre-pregnant state, but the muscles are forever going to be a little bit looser. Okay, so that's normal. We've already kind of talked, we're going to talk about episiotomies and all of that getting very, very shortly here. But be mindful of educating for hand washing, okay? Because not everybody washes their hands appropriately. You'll see your patients, they're going to get a perineal squeeze bottle, and that's really comforting for them. So how you use that, you can use warm water or cold water. I would ask your patient which they prefer. And just when they get up to use the restroom as they're emptying their bladder, what I want you to do is to fill up this bottle. It's nothing fancy. It's just a bottle. So it's a plastic bottle. So fill it up, whatever temperature the patient likes. And then after their bladder is empty, they're going to aim it on the perineum to clean off the area. And then they're going to take some toilet paper and they're going to pat dry. Okay? So that's what the squeezy bottle is for. Ice packs are very helpful in the first 24 hours. Not everybody likes them, but we always offer them because, again, I want you to think about the job that just happened on this part of the body. So you can put ice packs there. Some people prefer heat. So, again, it's a conversation with your patient. Do they prefer ice? Do they prefer heat? And then once you know what they prefer, you can have that conversation with them. So next we're going to talk about the focus assessment. My assumption is that in every department that you might work in, there's a focus assessment that matches that department. Well, this slide here talks about the focus assessment that goes with the postpartum patient. It's actually divided into two sections like this. It used to be on two separate slides, but there we go. Okay, let's talk about the top. So it's a bubble assessment. And again, I want you to assume that your patient is stable. I say that because if your patient is hemorrhaging we're not doing focus assessments, we're doing full assessments. And if there's anything untoward, we're not going to start at the breast, right? So if they're having a hard time breathing, let's start with the lungs. So the assumption here for the next couple of minutes is that our patient is stable. So we're going to talk about a bubble assessment, and the breasts. We're gonna want you to take. And if you're uncomfortable doing this by yourself the first time, that's fine. Maybe have your nurse there if they're comfortable being there, or if nothing else, have your faculty there. So what you're going to want to do is you're going to want to assess the breast to make sure that they're filling if they're choosing to breastfeed. And look for any cracks if they're breastfeeding. If they're bottle feeding, again, hopefully their milk hasn't come down. We're going to keep talking about that so we can prevent engorgement. So you're going to do a breast assessment. We already kind of talked about the U for the uterus. The first B is bowel and GI function. You guys already know how to assess this, so I don't need to cover this. B again is for bladder function. I want you to palpate the bladder. We already kind of talked about if your patient has an epidural during labor and what that means to your assessment, so I don't have to cover that again. The L is for lochia. Again, I've already covered that. And then the E is for episiotomy, okay? And the E actually goes down to this part 2 here. Definitely, you're going to do vitals and a pain assessment as well. So let's talk about the episiotomy, or even the it can even be for laceration too. Anytime you're looking at the perineum, if there's any kind of interruption in skin integrity there. All right, so then for your perineal assessment, it's REEDA, REEDA, and then watching for a hematoma. We're going to go through those, okay? So the best way to do perineal assessment is just like this picture says. Is it possible for you to take the patient's underwear down and have them kind of like in a lithotomy position so you can see? Yes, it's possible, but it's hard to see. That area is very sensitive, and they're not going to want you, your patients are going to be uncomfortable the more you touch it. So it's easier for both of you if you put your patient almost in a modified Sims. So you decide or ask your patient if they prefer the right or the left side, put them on their side or assist them on their side. They can move with their top leg all the way forward. Again, we're in this modified Sims position. And then what you're going to do is you're going to go ahead and take your hand and put it on the gluteus muscle and lift up a little bit so you can visualize the perineum. You're looking for any kind of redness, okay? Any kind of edema on the perineum, any kind of bruising on the perineum, discharge, perineal discharge. Now, again, this is not vaginal discharge. So if the incision, we're talking about the incision, is the incision red? Is the incision swollen? Is the incision have bruising on it? Is there discharge from the incision? Okay. Is it approximated? What that means, approximation means this. So let's say this is your incision, okay? And it's sewn up nicely. When it is approximated, it's well approximated. If you were to see your suture lines, they would line up like this. This is approximation. If you, quite to the contrary, if you are the opposite here, an unapproximated laceration, and again, this can be in any part of the body, we're just talking about the perineum here, is that instead of your sutures going straight across like this, they're kind of wonky. They're not lined up. Okay, so this is an unapproximated laceration. This is not good. You want a laceration that is approximated. The next thing we're going to talk about is a hematoma. Okay, a hematoma is not normal, and your patient will not know that they have a hematoma. What all a hematoma is a collection of blood under the skin. But when you have a vaginal or perineal hematoma, what's happening is that when the healthcare provider was doing the repair, there's still some bleeding that's happening behind the incision site and is dripping and collecting in this little pocket. And what happens is you have this, I want you to think of like a big grape, a big grape behind your incision. And so your patient doesn't know why it hurts so bad, but it hurts really bad. And they're going to put their call light on and they're going to say something is wrong. I'm in a whole lot of pain. You're going to give them pain medication and it's not going to touch it. Somebody who has a perineal hematoma is very, very uncomfortable. So you're going to inspect the perineum. If you see this swelling, and sometimes the hematoma gets so big, if we miss it, if I'm being honest. It can almost kind of push through your sutures, and then you're going to get your healthcare provider on the phone and ask them to come evaluate your patient because you want to make sure they don't have a hematoma. At this point, it now becomes back to the healthcare provider. And if somebody does have a hematoma, it is not uncommon that they have to go to surgery and they have to get the hematoma evacuated. So now let's talk about the breasts. All right, so part of our assessment, because we're talking about assessment, we're nurses, and nurses do lots of assessing. So we're going to want to make sure we know our patient's desires. Are they breastfeeding or bottle feeding? Are they doing both? And your labor nurses are probably already asked that, but you need to ask too as the postpartum nurse, because our job is to support them in their decision whether they're breastfeeding or bottle feeding. Let's talk about some definitions here. The first definition we're going to talk about is colostrum. So what colostrum is the early milk, and that's the milk that is at the very, very beginning of the breastfeeding stages. I want you to use your imagination. You have all seen honey before. If you haven't, when you go next time at the grocery store, go find some. I want you to assume you've got a little bottle of honey and a little bottle of water. And if you were to turn both of them upside down, the water comes pouring out of the top. It's very thin, okay? The honey drips slowly down the sides and slowly to the neck of the bottle, and then it drips out. Colostrum is like the honey, okay? It's very thick, it's very nutrition. The babies have to work hard to get it out, but it has all of the antibodies from the baby's mother, okay? So that's what colostrum is. The next word here, before we get too far, is a word that is called engorgement. All engorgement is fullness. So here we're talking about engorgement of the breast, which is fullness of the breast. Engorgement is very uncomfortable. It can happen to breastfeeding clients. It can happen to bottle feeding clients, and it's something that we'd like to prevent if we can, okay? Babies have a hard time getting latched on if somebody's breastfeeding to a very swollen, engorged breast. So again, education for your patient is really helpful in preventing engorgement. So when somebody has an engorged breast, you can have one side or both sides that's engorged, and if you were to touch it, it's going to be very tight because it's swollen, okay? So very tight, very tender, and very full and heavy. They're just going to be uncomfortable with that. And like I said, if this person's breastfeeding, it's really hard to get the baby on because the breast is so full, it can't get a good latch on it. So what do we do about it? Ideally, we can prevent it, right? But now let's just go with the scenario that we haven't prevented it, and now your patient is engorged. So if they're bottle feeding only, it will go away on its own. Encourage your patient to wear nice supportive bras and tight bras, and they can use ice in between feedings now because ice will help with the swelling, just like if you had a swollen arm. But the easiest way to put ice on breasts is to buy frozen peas. So have somebody go to the grocery store and buy bags of frozen peas, and then they can put those in some Ziploc baggies, and that way they can stuff them in their bra. So that works well. Also, cabbage leaves work well for engorgement, and this is the explanation down here of why it works for engorgement. If your patient is breastfeeding only, the best thing is to prevent it, right? And how you prevent it is to keep the baby on the breast. I'm going to rephrase that, not keep baby on the breast, is to keep the breast empty. So frequent feedings, all right? And before they put this baby to the breast, we want them to get a warm towel or a washcloth and put it directly on top of the breast because heat stimulates letdown. They can also, if they are at home and they have somebody to help them, they can take a really quick warm shower because, again, the heat will stimulate letdown. We want to make sure to prevent engorgement that we keep the breasts empty as much as possible, which means we're going to feed often. Okay, if we're breastfeeding and we have engorged breasts, like I said, it's really hard to get the babies on a really engorged breast. So you might encourage your patient to hand express some breast milk, gets that breast soft again, or to get a handheld breast pump and pump off some of their breast milk. Because again, it gets the breast nice and soft so we can get the baby to the breast. All right, let's talk about how we can help our clients who choose to breastfeed. There's different ways that a client can hold their baby. And that's what we're going to talk to you about right now. So if you know your patient wants to breastfeed and they tell you right out of the gates they want to breastfeed, what you want to do is you want to get that baby to breast as soon as possible for two reasons. Again, the quicker you get the baby to breast, it's going to help establish the breast milk. That's one reason. You want to get the baby to breast in the first 1 to 2 hours because that's when the baby is the most awake. After the first 1 or 2 hours, babies are going to fall asleep for at least 3 hours. And so it's really hard to get a sleepy baby to the breast. Because again, think about the honey and the water snare I just talked about. If you're going to put a sleepy baby to the breast and they have to work to get that colostrum out, they have to work hard and they just don't have the energy. So if you know your patient wants to breastfeed, you want to get that baby to the breast pretty quickly. So these are the different kinds of ways people can hold their babies to breastfeed. There's not one that's better than the other, if I'm being honest with you. Okay, a couple of things that that I want to talk about here is that if you look at all three of these pictures here, the positioning, the fundamentals are the same. So let's go with the scenario that your patient is right-handed. So if we're going to have the baby in either of these three holds here, what you want to make sure is that one of the hands is controlling the breast. So you're going to tell your patient to make a C with their hand, and they're going to put their fingers under their breasts and their thumb at the top of the breast, and that's how they're going to control their breasts. The baby is going to be, we always tell the patients, let's lay the baby tummy to tummy, which means the baby's tummy is right up against its mommy's tummy. And so the baby's not lying on its back trying to turn his head trying to find the breast. So look at all three of these pictures. Here's the tummy and there's the tummy. Here's the tummy and there's the tummy. So tummy to tummy is best, okay? And you're going to hold the breast, see, like this, the thumb on top and the fingers below, so the patient has control over their body. Put the baby as close to the breast as you can without actually getting on the breast, and you're going to tell the patient to drag their nipple across the mouth and the chin of the baby. What that does, that stimulates the rooting reflex, and the baby's going to turn towards the stimulation and try to eat. All right? So that will help them get the baby to breast. If the client chooses not to breastfeed, what we want to do is know that really early on, because you want to prevent the breast milk from coming in altogether. If they know they're not going to breastfeed, let's not have the milk come in, because then we're going to get engorged and we could get mastitis. So if we can prevent all of that from happening, it would be ideal. So if your client chooses not to breastfeed, we want them to wear a nice snug bra for 24 hours a day for at least 5 days, 5 to 7 days. That's the first thing you want them to do. Because again, with the breast close by the body, the breasts are nice and snug and the milk won't come in as much. That's the first thing. The next thing, they're going to avoid hot showers. I told you before that heat will stimulate letdown. So no heat against the breast, whether it's a warm compress or a hot shower, that's going to stimulate letdown. So don't do it. Tell your patient when they're taking a shower to turn away from the water coming towards them so the water is hitting them on their back, okay? That will help the milk not come down, and also avoid any kind of stimulation of the breast as well. Just a little conversation to be here about the changes in our body as our body goes back to its pre-pregnant state. So, the first couple bullets here talk about your normal blood loss during childbirth. Now, it's different based on the route. So you're going to lose less blood during a vaginal delivery as opposed to C-section, because C-section is major surgery. So those are your normal estimations of blood loss that you can expect. A couple of things too is it's not uncommon for in the immediate postpartum period for the white count to be a little bit elevated. So if you're looking at somebody's CBC and from 5 hours after delivery and then their white count's high, that doesn't mean they have a fever, an infection, right? Unless they're symptomatic elsewhere. Do they have a fever? Is the area tender? But if it's just the white count that's high, that's to be expected, okay? So a little bit here about the urinary system and the musculoskeletal system. Again, we're going to talked a little bit about the epidurals. If your patient had an epidural, it can lead to urinary retention because they don't feel the need to empty their bladder. So you're going to need to go back to do your health assessment, which you know how to do, and you're going to palpate the bladder and have that conversation with them too. Ideally, your client should be able to empty their bladder within 6 to 8 hours after having their baby. If not, we may have to put an in and out catheter, a straight catheter in to help get the bladder going again here. A little bit, tiny bit here about your joints. By the time you're fully through your postpartum period, which again can be about 6 to 8 weeks after having the baby, your joints are kind of getting back to where they used to be. They return to their pre-pregnant state. Your muscle tone is beginning to be restored. It's important that our patients do something called Kegel exercises. Some people call it Kegel exercises. It doesn't really matter. All it is, it's a way to strengthen the perineal muscles. And to teach your patient how to do it, what you're going to tell them is the next time they're emptying their bladder, as the urine is coming out, have them squeeze their muscles to stop. That is a Kegel exercise. All right. So as they're squeezing that muscle over and over again, it's strengthening the muscle. And that really will help strengthen that muscle and try to get back as close as we can to our pre-pregnant body. This is a very busy slide. I'm not going to read this to you, but this talks about some immunizations or injections that your patient might get when they're in the hospital. If your patient is going to get any of these injections, you want to make sure that your faculty is with you and that you can do this for your patient. Next, we're going to talk about the phases of maternal role attainment. During the first 2 to 6 weeks after the birth of their baby, your patient goes through a period of getting to know their baby. By 4 months, the new patient, or the new mother, if you will, the new mother has achieved the identity of being that person to this baby. Our first phase here of maternal role attainment is the dependent phase, which is the taking in. Now look at, this is pretty early on, right? First 24 to 48 hours. Yes, the patient's tired, but they're excited. They just had the baby and they want to talk about it and they want to hear about other people's birth experience. They want to talk about their birth experience. So that's the dependent or the taking in phase. The dependent independent phase goes after that, so 2 to 3 days, and it can last a little bit of time, right? They're focused on learning how to take care of their baby. They can have some baby blues and have some hormonal shifts there. And then finally we get to the letting go phase when the patient is able to focus on their family as a whole and as a unit. Siblings, assuming there are siblings, they kind of go through their own attachment as well and their own adapting to having this new baby in their new family. It's important that we as nurses assess our patients' attainment, and now that they're a new parent, are they adjusting to the way they should be? And again, in the hospital, we're going to be right about here and maybe some here. So you're going to want to know this, because if anything is not normal, you're going to need to ask the right questions and get them resources to help them. Next, our conversation is going to center around education of your patient and some discharge teaching. My goal is for you guys aren't going to be doing discharge teaching because you don't have a license yet, but I would like you to listen and participate so you can kind of see what your patients are being told by their nurses. Ideally, your discharge planning should start when the patient's admitted. So, and then that's even admitted into labor and delivery, because these questions we start asking them in labor and delivery, and there's a continuum of care when they go to postpartum until the point to where they go home. We as nurses need to employ lots of different strategies to get our patients involved in our education. And as you know, if you can get them to have return demonstrations or return teach backs, I guess, if you will, that's really great, because that way you could assess if they've learned what you've told them. So let's start with the perineum. So anytime you're talking to a female patient, you want to make sure that they understand that they have to clean their perineum from front to back, not back to front. They need to be on pelvic rest for 6 weeks. What that means is nothing in the vagina for 6 weeks. No sex, No tampons, just leave it alone, okay? We got to let that hair area heal. Next, we're going to talk about the breasts, and I have it kind of separated, breastfeeding versus bottle feeding. So our breastfeeding patients, again, we want to make sure that they're washing their hands, that they're wearing a well-fitting bra to help support those breasts, especially for your patients who have larger breasts. They're going to need more help supporting that tissue, and then avoiding underwires if all possible, because they can cause pinching of the milk ducts there. We no longer put babies on a breastfeeding schedule. We used to a long time ago, and now the research has shown that that's not the best way. So we basically have the baby eat on demand, and so watch for clues that the baby's getting hungry. And those clues are going to be when the baby starts licking its lips and it starts turning its head and looking for food. You want to tell your patient when they start seeing that, they need to get up, empty their bladder, get themselves situated, and get ready to feed the baby. Breastfeeding, as much as it's something that is a, quote, normal and natural thing, can be hard for some patients to do. And especially if your baby's really sleepy or a little bit on the premature side, it can be really hard to get a baby to breast. So we want to make sure that we don't wait until the baby is screaming to get the baby on the breast. Watch for the signs the baby's getting hungry and get ready to eat that, to feed that baby. Talk about ways to prevent engorgement. We've already kind of talked about that, and ways to relieve it once it happens. Caring for our cracked nipples. Again, anytime you have a crack in your skin, that is an area where bacteria can get in and cause an infection. So if your patient has an incorrect latch when they're breastfeeding, chances are really good they're going to have cracked nipples. And the reason is because when you get the baby to the breast, the baby kind of makes like a little taco tongue with its tongue, and it opens its mouth really wide, and the patient's going to put the baby onto the breast. Breastfeeding shouldn't hurt if the baby is on correctly. If the baby is not on correctly, 9 times out of 10, the patient's nipple is hitting the hard palate of the baby's mouth. And as the baby is pulling to get that colostrum out, because again, think of the honey, right? Baby's pulling really hard to get the colostrum out. That nipple's getting rubbed over and over and over again at the hard palate of the baby, and that can cause the cracking. And anytime you have cracking, you can get bacteria in there, and that's what can cause infections of the breast, which we're going to talk about in a little bit. If their nipples get sore from breastfeeding, because they can, what you want to tell them to do is when they're done feeding their baby, to express some breast milk onto their skin and to rub it on their nipple area and the areola, and keep the clothes of the patient's clothes off for a couple of minutes until the area dries. And they must make sure they drink lots of fluid, because otherwise their milk will dry up. For our bottle feeding patients, I already told you they need to have a nice snug bra on for 72 hours. That's 3 days. So I would say a little longer than that, but certainly at least 72 hours. We already talked about how we avoid warm water because warmth stimulates letdown, and how to treat engorgement, which we already had talked about. All right, so we're still talking about discharge teaching here for our patients. So we want to make sure that the patient is aware of their limits in their activity. And a lot of that's going to be on how they had their baby, vaginally versus a C-section. They can go ahead and do pelvic tilt exercises, because that will help strengthen their back, and that will help relieve any kind of back pain from when they were carrying that baby. That kind of puts your body as like a sway back position. So once the baby's delivered, having them stand in a pelvic tilt will help with that back soreness from that. If your patient delivered vaginally, they should limit climbing the stairs, ideally for at least a couple of weeks. But honestly, if they have a 2-story house, hopefully they just have someone to help them. If they had a C-section, they should not lift anything until 4 to 6 weeks, okay? Because again, they have a cut on their abdomen. We typically will tell them not to lift anything heavier than their baby. That's just easier. I'm sure the book says don't lift this many pounds in this many weeks, but realistically speaking, if you just tell your patient, don't lift anything heavier than your baby, they know kind of what that means to them. Also, to sleep when the baby sleeps, because babies are their schedule's kind of wonky when they're first born. So sleep when the baby sleeps. If somebody's breastfeeding, this is the caloric needs they need to have on board there versus the bottle feeding patients. Both of your patients are going to probably be taking their prenatal vitamins. They're going to keep eating things that are high in protein because that helps with the healing process as well. So the next thing we're going to talk about is sexual activity. This data comes directly from your book. It says that is they can safely resume sexual activity by the 2nd to 4th week when the lochia stops. Most of the healthcare providers that are around and all the research that I have read, with the exception of your textbook, says that people should be on pelvic rest for 6 weeks after having your baby, because that's when the lochia flow has completely stopped and the area, the placental site, the area is nice and closed. Sometimes, because of the shift in our hormones with having a baby, we can have experienced vaginal dryness. So we want to make sure that we educate our patients that it's okay, that they can use over-the-counter lubricants for sex to help things not be so dry until that kind of figures itself out. And they also might have a decrease in libido initially, again, just because of their hormone shift. We already kind of talked about contraception when we talked about a couple slides ago. I already told you that the patient can still get pregnant even though they're not having their periods when they're breastfeeding, because they're still ovulating once they get kind of past those initial first few weeks. So talk to them. If they're trying not to get pregnant, let's have that conversation with them and empower them to make the choice as far as contraception. Ideally, if they want to take the birth control pill to prevent pregnancy, you want to make sure we wait until the breast milk is and the breastfeeding is very well established. But since you're typically not having sex until 6 weeks after having your baby anyway, chances are good by 6 weeks out, your breast milk is already well established. If they do want to take a birth control pill to prevent pregnancy, they will take a progesterone-only birth control pill. And we talk about that in week 6 in the wellness lecture. But you can either have birth control pills that are progesterone only or progesterone and estrogen combination. The estrogen will dry up your breast milk. So if somebody is breastfeeding, we want them to not take the estrogen there. Finally, we want to make sure that our patients know when they're supposed to follow up with their healthcare provider, right? So that's going to depend on, again, we're assuming that everybody is stable, right? And nobody is having complications here. But if somebody's had a vaginal delivery, they're going to go see their doctor 4 to 6 weeks after having their baby, where a C-section, they're going to go 2 weeks out. It's very important that you let your patients know what to report and who to report situations to. And the bottom here talks about the things that they need to report out. Now, remember, your patients are going home very tired and this huge life change because now they have a brand new baby they have to take care of. And again, chances are good they've been up for a couple of days. So you want to make sure that this is documented for them and they understand how to get a hold of who they need. Do they have a fever? Change in vaginal discharges? Any kind of changes of incision? And again, the rest of this, I think, is very self-explanatory. We're going to talk about postpartum depression and baby blues in just a little while here. The next piece of this lecture talks about all of these postpartum disorders. And the thing is that as much as having a baby is, quote, a normal thing to do, we must always understand that having a baby can also have some untoward things happen. And these are all the untoward things that can happen. So let's be aware of them together so we can help take better care of our patients. A little bit here about DVT. So we have the understanding that our patients, our postpartum patients, are at a greater risk of developing a DVT, and the DVT can lead to pulmonary embolism. So careful assessment and understanding on our part are going to keep our patients safer. Going to keep our patients safer. So who is at risk and why are they at risk of developing this DVT here? Well, pregnancy, I listed that as first because that's our clientele. And because of the estrogen in our bodies, it automatically puts them at risk for developing a DVT. Operative, I'm just going to go through things that you might not know what they are. So an operative delivery, that means a vaginal, well, I guess a C-section too. Any kind of delivery that when you use a vacuum or forceps, that's an operative delivery. So all of these are risk factors of developing a DVT. And if we're going to go and assess our patients, these are the things that we're going to find when we assess their body, okay? And how we diagnose it is right here. So just like everything, prevention is key, right? Especially if we know our patient falls in that previous slide under the risk category. So if you know your patient is at risk, and let's be honest, everybody who's pregnant is at risk. We already kind of talked about that, but there's other people that are at risk too. So these are the ways that we can prevent a thrombophlebitis from happening. All right, and we're going to teach our patients to avoid long periods of sitting or standing. When they are sitting, to elevate their legs. Don't cross their legs, right? You want to keep them not crossed at the ankles or at the knees. Increasing the fluids and stopping smoking. Hopefully they aren't smoking anyway. And then if they do get diagnosed with thrombophlebitis, this is what we have to do and to manage it. We keep them on bed rest, okay, with the extremity above the heart. And we're going to alternate these warm, moist compresses, but we're not going to massage the area. All right, we don't want to dislodge anything. Part of our care can also be to do a measurement, like the circumference of the area, because that will help us establish if things are getting bigger or things are getting smaller. And then we can have them wearing TED hose if they're at risk for getting them. Administering NSAIDs will help with the pain, and anticoagulants as well, which is on our next slide. So we have separations here. We have heparin and warfarin. All right, those are the two things I'm going to teach you about today on managing somebody with thrombophlebitis, okay? So a heparin, as you know, is an anticoagulant, and it's given IV, and protamine is our antidote for it. People that are on both of these drugs, whether it's heparin or warfarin, give them the same education. Report if they're having excess bleeding from their gums, increased vaginal bleeding, those kinds of things, okay? So warfarin's also an anticoagulant, but it's PO, okay? And they have different antidotes. And you cannot take warfarin when you're pregnant. So if somebody has this bleeding disorder and they're getting pregnant, they're going to have to find something else for them to take. And this is the education you would give somebody if they're taking any kind of anticoagulants there. So here is just a visual. Lots of my students and lots of nurses are visual people. So I like to put in visual things as much as possible here. So this just is a visual for you guys to see what happens when somebody has DVT. So a bit about coagulopathies before we, this is going to lead us into our postpartum hemorrhage conversation, okay? So I would think that, these are definitions. You have idiopathic thrombocytopenia and then disseminated intravascular coagulation, you will mostly see in the OB world, if you're going to see it at all, somebody having issues with DIC, okay? And DIC is not only found in the OB world. DIC can happen when a person is losing large amounts of blood rapidly, okay? So these on this slide is kind of separated left and right. So the people that are at risk for developing coagulopathies are people here on the left-hand side. Now, some of these things you don't know yet. Some of these things we're going to talk about in week 4, and I'm just going to outline the things that I'm going to talk about in week 4. These, and this. All of the red marks are things that I'm going to teach you about in the high-risk antepartum content, okay? So right now, what I want you just to do, you don't have to understand these today. You will understand them when I teach it to you in the high-risk antepartum lecture. But know that these high-risk things, these red tag marks here, you don't have to understand them for this content, but these specifically are at risk for these coagulopathies from developing. Fetal death in utero, okay? People who are septic, people that have gone into cardiopulmonary arrest, people that are hemorrhaging are at risk for having these coagulopathies develop. Somebody that's in DIC, that's what most of us have seen in this world the most, but people that are having these kind of coagulopathies, it happens very fast, and it can be very scary. They start bleeding out of every orifice and every opening in their body. Okay, gums, nose. If they have any incisions, like a vaginal laceration or episiotomy, or a C-section incision, their IV site, anything, any kind of interruption in the skin where there's an opening, they're going to start oozing and trickling blood. Okay, it happens very fast, and it's very scary. So ideally, we have enough time to draw some blood, and we're going to find these things of the blood work that we're going to draw. We're also going to draw our patient's blood type and cross-match them, because we're probably going to have to give them blood because they're going to start dumping blood out of their body. So now we're going to start putting it back in. All right. And these right here is what we do if our patient is in DIC. So now we're going to talk about uterine atony. Uterine atony is the inability of the uterus to contract adequately after having a baby. And I already talked about it. The uterus is just a big muscle. And the muscles, the contractions happen. You got to keep that muscle firm so we don't have a postpartum hemorrhage. If we have a uterus that's not contracting, it can lead to uterine atony, which can cause a postpartum hemorrhage. So people that are at risk for uterine atony, anytime you have anything retained inside the body, placental fragments, amniotic membrane fragments, okay? Somebody with a prolonged or very, very short labor is at risk for uterine atony. Somebody who has an induction or has received oxytocin. The reason I'll kind of talk about that a little bit. Anytime you give somebody medication, there's receptors in our body that receive the medication. Okay, I want you to use your imagination again and think of these receptors as they're like little openings. Their body has this little hands open inside to receive these medication, these receptors. But once those receptors are full, it can't take in any more medication. So go back to this third bullet here. If your patient has been on oxytocin for whatever reason for a long enough amount of time, those receptors get filled up. So when we need to give them oxytocin after having a baby to keep that uterus contracting. It doesn't work because the receptors are filled up. That's what that means. Overdistension of the uterus. The bigger the uterine muscle is, the harder it has to work to contract, and sometimes it just doesn't want to do it. So even an overextended uterus, that can lead to postpartum hemorrhage too. Magnesium sulfate administration. I teach you about magnesium sulfate in the high-risk antepartum lecture as well. But all I want you to know for right now is that magnesium sulfate acts like a big muscle relaxer. So if your patient's on magnesium through the IV, it relaxes all the muscles, including the uterus. And a relaxed uterus doesn't contract well. Any kind of trauma during labor as well. So when your patient is having uterine atony, below here, these are the things that they're going to find on your assessment. And here, what are we going to do about it? That's how I've listed that. So let's have a discussion about a postpartum hemorrhage. So by definition, a postpartum hemorrhage is the loss of more than 500 mils of blood after a vaginal delivery or more than 1,000 mils of blood after a C-section. A postpartum hemorrhage can result in hypovolemic shock and anemia, okay? So the goal here, you guys, the goal here with any kind of nursing, but certainly right now in this conversation, is to know the risk factors and get in front of it. Because otherwise you're playing catch up trying to help your patient. But if you understand the risk factors, you can be prepared and prevent this complication or any complication. So what are our risk factors for a postpartum hemorrhage? Our risk factor, the number one risk factor, the primary cause of a hemorrhage is uterine atony. So you would have to understand how to prevent uterine atony. If you can prevent uterine atony, chances are really good you can prevent a postpartum hemorrhage. And again, these are all the other risk factors here, and I do believe that a lot of this is self-explanatory. There are things that I haven't taught you yet. I'm going to teach you in the antepartum high risk lecture. This one. These are all things that we're going to talk about in the antepartum lecture. But everything else we've already covered. So what is our assessment on somebody who is experiencing a postpartum hemorrhage? Well, if nothing else, the first thing that's going to happen is you're going to notice that we have a boggy uterus and we have a change or an increase in a lochia pattern. All right. There's going to be clots that are bigger than a quarter. And we already talked about measuring clots based on coins. It's easier. Well, a quarter is bigger than a dime. And I said sometimes you can have even a nickel if you really want to. But when you have clots that are bigger than a quarter, you better start paying attention. Certainly when it's accompanied with increased lochia and a boggy uterus. Constant trickling or frank blood flow coming out of the vagina. We already talked about that and why that is an issue with postpartum hemorrhage. So you understand the risk factors. We know what your assessment's going to be. Now, what are you going to do about it, right? Keep in mind your nursing process, right? You have to have an assessment before you understand what's going on. And now that you have identified, you're hypothesizing that your patient is having a hemorrhage. And this is why. My assessment says A, B, and C. So this here talks about the things that we're going to do about it. All right? Now, what I want to pause for a second. Considering established 2 lines, what that means is 2 IV lines. But I want to stop for a second. If your patient, when you're admitting them, has any of those risk factors that we talked about on the previous slide, you may want to call your healthcare provider and in the interest of getting in front of a problem, trying to prevent it, call your healthcare provider, give a very nice SBAR, and your recommendation is, can I have orders to have a second IV site, and I will just use it as an IV lock. And this way, if you need it, it's there. And if you don't need it, you can just DC it. It is very hard to gain IV access when somebody is hemorrhaging. Okay? So again, know your risk factors. And if somebody is at risk for a postpartum hemorrhage, let's go ahead and get orders to get this second IV lock here started, IV line access point here started. Watch for a bladder distension, because if the bladder is full, like we've talked about, it can displace the uterus, and a displaced uterus from the midline can also be a problem with the postpartum hemorrhage. So you might want to put in a Foley catheter. You're going to massage that funnus until it's firm. What if it never gets firm? Then that means you never leave. All right. Do not leave your unstable patient. And a patient with a boggy uterus is not stable. If you get tired from doing your massaging, have somebody step in to help you out. Okay. Figure out where the bleeding is coming from, give them some O2, and elevate those legs. Here are all the different medications that we use to treat a postpartum hemorrhage. Most hospitals now have a postpartum hemorrhage card, and we talk about that in just a minute. But these are the meds that go along with treating our patients who are needing them. What I will tell you is that it is not our decision as a bedside nurse, which is what we're practicing for today. We're not an advanced practice degree here. So we do not give orders. We execute orders that we've received from our healthcare provider. You may work with somebody who wants to give Methergin before they give Cytotec. That's fine. Okay. So just because oxytocin is here first doesn't mean that's everybody's favorite drug. I was just listing them. Okay. So you'll notice that under classification, most of them, with the exception of TXA, are uterine stimulants. Okay. Oxytocin, I've already taught you about. I taught you about it in the labor lecture. Oxytocin is given here in a different dosage, of course, because now we're trying to keep the uterus contracted. We want to keep that uterus contracting so we can treat this postpartum hemorrhage. Ideally, you have an IV site. If not, you can give it IM, just a different dosage, okay? So that'll be patient-specific there. Methergin or metherglonovine. Methergin is always given 0.2 milligrams IM, all right? Again, to control our postpartum hemorrhage. The thing with Methergin, it's a vasoconstrictor. It kind of goes along the lines with your Hemabate, all right? So because they're vasoconstrictors, if your patient has hypertension or asthma, we're not going to give this medication, okay? We're going to give something else. I'm going to go ahead actually and go down and talk about Hemabate because that's more similar to Methergin up there. Hemabate is given in 250 milligrams, and it's always given IM. And it's given to control a hemorrhage, what we're talking about now. I already talked to you about hypertension. I talked to you about asthma. The thing that's different with Hemabate is that it can cause pretty significant diarrhea to our patient, which in the middle of saving their life, are you worried about that? Probably not. But you want to make sure that after you've saved their life, you understand that they're going to be in the bathroom a lot because they're going to have diarrhea from this Hemabate. The next thing we're going to go to is medication called Cytotec or misoprostol to control a postpartum hemorrhage or to treat a postpartum hemorrhage. We can use this medication, and almost always it's given rectally to treat a postpartum hemorrhage. The dosing is going to be different than the dosing that you're going to give to augment or to induce somebody's labor. So it's going to be given a different dose. It works really, really well, and it works really, really fast. And finally, TXA, and this is given IV. Now, this is a little bit different, all right? Where most of these drugs, actually all the drugs up here, as soon as you give them, they're going to work. Certainly your mucous membrane medications first, like your rectally Cytotec, that the absorption's really fast. IV medications, your absorption's really fast. IM's a little bit longer, but this is actually given IV piggyback over 10 minutes. Yeah, I guess you could push it too, but it goes over 10 minutes and within 3 hours of delivery. So you have a little bit more time for to give this medication. Still talking about a postpartum hemorrhage. There's something called the California Maternal Quality Care Collaborative. The acronym for that is CMQCC. I have a bunch of information in Canvas for you guys to reference. I didn't want to put it all on the slide. It gets to be really busy, but I will direct you to your Canvas resources for this week, and you'll be able to look at things like there's an algorithm that is developed through CMQCC that basically it says if your patient is a level 2 hemorrhage, this is the order that we do things at. So all this stuff kind of comes out of CMQCC. And I'd like you to take a peek at it because that's how we all are going to run our hemorrhages. I would love for you to at least witness a postpartum hemorrhage because almost all the time there's a good outcome, which is good. And I want you to see I want you to witness the teamwork that the nursing staff and the support staff do to save this patient's life. If a hemorrhage is happening, you can do things like retrieve the hemorrhage cart, retrieve the crash cart, but and you can be more of that, have that kind of a role as a student. If the patient does lose consciousness and code, you have BLS, you can do compressions and those kinds of things, or you can just watch. But I don't want you to walk away. I would like you to watch what happens and the steps that these nurses and the nurses here do and the team do here to save this patient's life. So a little bit about CMQCC, which is just what this is. And again, CMQCC is something that us and OB really, really base a lot of our care on. Whether it's the OBGYNs or the healthcare providers, as well as the nurses. This is an organization that's committed to ending preventable morbidity, mortality, and racial disparities in California. It has been around a while here, since 2006, and it was because there was a rise in maternal morbidity and mortality. And so a group of folks got together in 2006 and began this CMQCC with the goal to save people's lives. Since it's been started, the mortality rate in California has decreased by 65%. So that's really good. So whatever was happening in this collaborative group is working to save people's life. I just put varying pictures here for you. The picture, let's start, it's not kind of out of order. Let's start with this right here. What this is a hemorrhage cart. So in the hospital, I'm hoping you guys know where the crash cart is. So if your nurse says, go get me the crash cart, you don't say, I don't know where it is. You need to make sure you know where that is. Also, in our world, you want to make sure you know where the postpartum hemorrhage cart is. There should be one in labor and delivery, and there should be one in the postpartum unit, probably behind the doors, and it might be locked. So if it's locked, of course, you might not be able to get in. But you want to know where it's at because in case they do ask you to fetch it, you want to know where it's at. It's typically going to be locked very similarly like your crash carts are, all right? But they will open it as they need to. On the very top here, which I know it's not on here, but there's a scale. It's a very small scale, and that's how you're going to weigh all of your chucks and all of your pads to establish a quantitative blood loss for your patients. Quantitative means that you're not estimating it by looking at it, you're actually weighing it and getting hard numbers. And then in each one of the drawers, this one happens to be labeled. Each one of the drawers, there's equipment that you, the nurses, are going to use to save your patient. Again, before we had these kinds of carts, we still did our job, but there was a delay in care because we would leave the room to get our Foley and come back in. We'd leave the room to get our IV supplies and come back in. By bringing in this cart, everything is there. The meds may not be in there. You're still gonna have to, someone will have to go out and get those for you, but the equipment that you need should be right here. Within this hemorrhage cart, we're gonna start here. This is called a Bakri balloon, Bakri, a Bakri balloon. The Bakri balloons and the Jada, these are not put in by us as nurses, right? We assist in all of this. By the time the decision is made to put a Bakri balloon in, chances are very good your healthcare provider is there. You've already tried a bunch of meds, the one that we've already covered, to see if we could save before we can not have to use these tools, okay? But if they're gonna have to use these tools, that's fine. What they'll do, and I can't tell you which one they're gonna use over the other. I can tell you the Jada system is new, so not all the hospitals are gonna have it, but it just depends on the person who's actually doing the procedure. What a Bakri balloon is, it's just a tamponade. It's a uterine tamponade. There's this small flexible tube right here, not very long at all. And then at the top here is a balloon. That's what this is here. So what's going to happen, they're going to take your patient to the operating room. They're going to give them a twilight sleep or put them to sleep or activate their epidural, whatever. That's kind of patient specific, but either somehow they're not going to feel it. And they're going to put them up in stirrups, which is lithotomy position. And they're going to put this tube in. And they're going to put the balloon up inside the uterus and they're going to fill it with fluid. And it typically holds about 500 milliliters. And what it does is when it's full of fluid, this balloon compresses the sides of the uterus. And at the top, if you were to look at it, at the very tippy top right here, there's the top of the catheter is there, or the tube. I like catheter better. And there's holes in there because if we still have bleeding happening, the blood is going to go in through this tube. And then once this gets put in, you're going to go to central supply and get a Foley catheter bag, and you're going to attach it right here. And then this patient will not be going to postpartum. Well, it depends on where you work, but our job as the nurse here taking care of this patient is to do INOs because we are to measure the blood that's coming out of the uterus and collecting in the bag. So that's the Bakri balloon. This here is the Jada system. And this is actually brand new on the market. Like I said, not all hospitals even have it yet. So it just depends on your healthcare provider and what they want you to do. But this actually looks just like this. It's a little loop, like a circle. It actually looks that's what it looks like. And they're going to it's flexible, bendy. They're going to put this inside the uterus and it's attached to low suction. And that will help pull out whatever blood is collecting here. And it will come out when the contractions stop the postpartum hemorrhage and the patient is deemed stable. They will take the Jada out. Now let's talk about subinvolution of the uterus. I know these words are all kind of new to you, so we're going to go through them. So what is subinvolution of the uterus? What that is the uterus remains enlarged because the lochia keeps coming. So the uterus is not contracting and it stays big. All right. And it can result in a postpartum hemorrhage. So who is at risk for experiencing subinvolution of the uterus? Somebody who has any kind of infection and somebody who has anything retained inside their body after having their baby. Placenta fragments, membrane pieces, those kinds of things, okay? Because that prevents the uterus from contracting. So that's who's at risk. Well, how will you know? That's your assessment. You're going to go in, you're going to talk to your patient, you're going to figure out that they're bleeding. Remember the stages of lochia we talked about in the beginning of this lecture? They're not going through that as they should, all right? When you palpate the uterus, it's going to be bigger than it should be, and it's not going to be firm because it's not contracting, okay? So this is what your assessment is. And so what are you going to do about it? You're going to call your healthcare provider and you're going to give a very good SBAR. Part of your background is this risk factor, your assessment. You're going to ask, your recommendation is these lab tests. And something that these are the things that can be done for somebody who's experiencing subinvolution of the uterus. I'm going to come back to the first one. We're always going to monitor vitals, and we're going to encourage our patient to do things that can increase uterine involution, which is the contractions, right? Which actually is helped via contractions. If they are breastfeeding, let's get that baby to breast, because we know when the baby's on the breast, it releases natural oxytocin inside the client, right? So that will help the uterus contract. Let's put the baby to breast. Let's have them get out of bed and have them empty their bladder. We certainly can give them uterotonics, right? And antibiotics if they're infected. Let's go back to the first one, dilation and curettage. What that is, if it is established that there are retained placental fragments or membranes in that person's body, they will have them sign a consent for a D&C, which stands for dilation and curettage. So they will go to the operating room. They're going to have be somehow made where they can't feel what's going on. Whether they have like a twilight sleep or a total general anesthesia, I can't say. But what they're going to do is they're going to, again, put them up in the stirrups, which is a lithotomy position, and they're going to use tools to go in and to get whatever is left inside the uterus out. They might just be able to reach it and grab it. That's ideal too. But if not, there's tools that they can use, sterile tools, to help them go in and get whatever's left inside. All right, let's talk about retained placenta. I want you to think about the labor lecture. And in the beginning of the labor lecture, we talked about the different stages of labor. And one of those stages is when we have the birth of the placenta, the delivery of the placenta. Well, when the placenta does not come within a certain amount of time, it is called a retained placenta, all right? And anything that is left in the body can lead to uterinatony, which can lead to a postpartum hemorrhage, or it can lead to subinvolution of that uterus, and I just talked about that. So these folks here are at risk for having a retained placenta, okay? I think those are all pretty self-explanatory. What I will say for this part here, this preterm birth between 20 and 24 weeks, I will say that the earlier the pregnancy, where the fetus comes out, remember, this is very early, this is non-viability, right? 20 to 24 weeks, the fetus will come out, but the placenta will be retained. And that's pretty common for these very early losses here. All right, let's talk about the findings. So what is our assessment going to be like on a patient who has a retained placenta? Well, we're going to have excessive vag bleeding with large clots. We already talked about that. Uterinatony, we've talked about that. Vag discharge, malodorous lochia, and hyperthermia as well. Those are new ones for you right now. What are we going to do about it? We're always going to assess for fundal height, monitor lochia. If it's not uncommon that they will go ahead and have a D&C done to go in and get whatever's left inside. If the bleeding is continuous, they may have to have a hysterectomy, although that isn't that common anymore, but it can happen. And we're certainly going to give uterotonics to help with that uterus to be contracting. So let's talk a little bit about lacerations and hematomas. I feel like we've covered it already, so I'm going to kind of breeze through this slide here and then get us right into postpartum infections, which will complete our time together for this content area. So I already told you what a hematoma is. These individuals are at risk for having a hematoma. And your patient who has a laceration, now laceration again can be anywhere, but let's talk about a perineal laceration. A perineal laceration, somebody who has a perineal laceration, They're going to have continuous oozing or trickling of blood from the vagina despite that fundus being firm. So if you're massaging your fundus and we know it's firm, but they're still having more bleeding than you expect, more bleeding than you expect, start thinking about a laceration, all right? A hematoma, I already told you what that was. So what are we going to do about it? Assess pain. So assess the area, right? Evaluate your lochia. Do an S-bar, and your recommendation is to have your healthcare provider come evaluate as well, okay? Because both of these things are abnormal. So let's go ahead and get our healthcare provider at the bedside as well. The last piece of this content speaks about infections during the postpartum period. Now look at, these things can occur up to 28 days following the birth of a baby or an abortion. Infections can happen for 28 days. These patients are long gone from the hospital. So we as nurses need to equip them with the knowledge that they will know when to escalate to their healthcare provider that something is going wrong. These are the things that we are concerned about. This low-grade fever, or even a little bit higher, but here's the timing. First 24 hours during the first 10 days, okay? So the fever after the first 24 hours, but before 10 days. Now remember, your patients are going to be home, so tell them what to watch for. And you can have an infection anywhere. The bladder, the uterus, the wound infection, the breast, it can lead to septicemia, right? So teach them what to watch for. Down here, what I'm going to talk about here is the incidence of infection, right? That's what this means. So after a spontaneous vaginal delivery, just all by itself, it's kind of a low, and there's a low chance, 1 to 3%. After an elective C-section without ruptured membranes, so that means they have a scheduled C-section, their membranes weren't ruptured, you still have a risk of having an infection, but still not that high. So if your person has been in labor and then they're having a C-section, and this one even talks about the membranes are ruptured and prophylactic antibiotics, the chance of becoming infected goes up. And then here, it's even higher if they don't get antibiotics. So I want to talk a little bit about these last two here. A lot of students get confused on how long is too long to be ruptured before we're worried about getting an infection. So I want you to know that whenever someone's membranes are ruptured, the chance of becoming infection is higher, right? Because that protection, that water balloon around the baby has a hole in it. So we as nurses have to do careful assessments. The longer somebody's ruptured, the greater the risk they're going to become infected. If they're ruptured like, I don't know, 12, 14 hours, I don't love that as a labor nurse. I might be checking their temperature more often. I'm going to be palpating their abdomen or making sure that they're not having an infection somewhere. But when we're talking about 18, 20 hours being ruptured, you might have some physicians who want to put their patient on prophylactic antibiotics. And you might see that, and you might also see that they're going to wait until the patient becomes symptomatic. Fever, those kinds of things, okay? This bottom bullet here, so what I want you to tell you is pretty common practice now, thanks to all kinds of research, that before somebody has a C-section, regardless of the reason, before they do that first cut, that first incision on the abdomen, the patients are going to get a dose of IV antibiotics because the research shows that even if they just get one dose before the incision starts, it decreases their chance of getting a postpartum infection. So here, these are all the people that are at risk for becoming infected. Holy smokes, there's a lot there, right? Again, I've covered all of these. Yep, I've covered all of them. So these are the risk factors. And again, a prudent nurse is aware of the risk factors and gets in front of any complications. That's what I'm going to keep saying. And you're going to have to get used to being that kind of a nurse. Your patients really deserve that kind of a nurse. So we're going to go ahead, just like any other kind of infection, we're going to get lab work done. They can, if they might do cervical cultures or intrauterine cultures or cultures of the placenta, it just depends on what's going on. And certainly a CBC as well. And we as nurses are going to always be, a lot of it is assessment. Assess, assess, assess. Assess vitals, assess pain, assess fundal height, assess lochia. I mean, we're assessing, assessing, assessing. All right, so let's talk about this word here. It might be a new word for you. This word is pronounced endometritis, all right? Basically, that's a fancy word for a uterine infection. It's an infection within the uterine lining. It's the most common postpartum infection. And again, the third or fourth day is when the patients are going to notice it and they're going to be at home. So teach them what to watch for so they can call somebody and get treated before it gets too bad. And somebody who has endometritis, it starts with that placenta. Remember, that placenta was attached to the uterus and now it's not there. So what you have is that wound. And so there's an infection, there's bacteria that has gotten into that wound, and then it spreads to the entire muscle. So your patient is going to complain of pelvic pain and chills and fatigue, and then you are going to go in and do an assessment, okay? You're going to check their vitals. You're going to check their lochia. You're going to get on the phone. You're going to call your healthcare provider, and you're going to ask for a recommendation here. Cultures possibly, certainly antibiotics and pain meds. Next is mastitis. So mastitis is an infection in one or both of the breasts. Mastitis can lead to septicemia because it is an infection. It can lead to an abscess on the nipple or the area. Typically occurs the 7th postpartum day. Again, your patients are home. Teach them what to expect, what is normal, when they should call their healthcare provider. And staph is usually the bug that's the organism that causes this mastitis. So these individuals here are the people who are at risk of developing mastitis, okay? So again, try to get in front of it. If your patient has any of these things, lots of teaching before they go home, okay? Stasis of milk, that can be caused from engorgement. It can be caused from a blocked duct, okay? Nipple trauma because of a poor latch when breastfeeding, typically. We talked about that earlier in this lecture here together. Decrease in frequency of breastfeeding because a decrease in frequency of breastfeeding can lead to engorgement, and engorgement can lead to mastitis, okay? So those people are at risk. So what we're going to do is we're going to go in and we're going to do an assessment. And here talks about what we're going to find on our assessment. When you palpate the area, don't palpate too hard, it's going to hurt them, but it's going to be sore for them. It's going to have a hard mass there. It's going to be red. They're going to feel like they have a really bad flu, the lethargy, the fatigue, the body aches, okay? What they're going to do is they're going to be instructed to call their healthcare provider. And, that's the next slide, sorry. Warmth will actually help if you put a little bit of a warm compress on that slide. It will help. So here are the interventions. So again, they're going to be hopefully instructed in that before they go home from the hospital, their nurse should tell them if you experience any of these symptoms, things I just told you about, they need to call their healthcare provider, all right? And they can anticipate their healthcare provider. Some of them will bring them into their office, some of them won't, but regardless, they're going to be given antibiotics, all right? So we want to also teach them that if they're using breast pads in their bras when they're breastfeeding, breast pads, I'm going to pause. What breast pads, they're usually discs the size of about a nice small grapefruit, so they're round, and they just go in the bra between the skin and the bra itself. And in case somebody has a leakage of breast milk, it helps to kind of soak it up. But again, breast pads with breast milk on them, and if the nipple is cracked, that can be an avenue to get bacteria in there. So we need to have them change their breast pads frequently. After they breastfeed, I already talked about splashing some breast milk on and letting the nipples air dry before you put the bra or the shirt back on. Make sure your patient understands how to correctly latch the baby, and I've already taught you that. They can use warm packs that will help certainly with letdown, but also ice in between feedings because that will help with the pain. Increase fluids because they are sick, and wear a nice, well-fitting bra. The last topic we're going to talk about for this content is postpartum depression, baby blues, and psychosis, okay? So the beginning here talks about all three of them. So baby blues that's the one that's the most common. Look, 85% of us experience that within the first few days, and it lasts up to 10 days. Postpartum depression is less frequent, which is good because it is more of a mood disorder, all right? So postpartum depression occurs within 10 to 15% of new parents, and it can be within a whole year, all right? So the timing's different. And then postpartum psychosis, thankfully, is not that common. This is the one that you hear about on the news maybe, or when people hurt themselves or they hurt their babies, all right? So who is at risk for developing any of these three? Well, look at the first one. That's a problem because everybody who's had a baby has hormonal changes. So that's why it's pretty, baby blues are really common. And then you have other things that that can make somebody at risk for the development of these issues. So here I have it separated into all three of the different kinds of depression. We have baby blues, postpartum depression, and postpartum psychosis. These are the things that your patients are going to experience based on whatever one that they're in. What I want to make sure is that I want to make sure you guys are not making assumptions. I have heard nurses and students in the past that say things like, well, my patient is very affluent, or my patient has lots of family, or they live in an affluent community, so they're not as prone to this. Sure, people that have differing socioeconomic factors are more prone to it, like the slide before says. But again, if you look at the numbers, 85% of new moms will develop baby blues. So that's a lot of people. So I want to make sure that you're not making assumptions. Do a thorough assessment so you can establish safety of both people, the baby and the mom, and then your assessment will help you figure out if your patient is experiencing baby blues, postpartum depression, or postpartum psychosis. So what are we going to do about it? It's important that we bring in the patient's significant other, whether that's a partner, that's a husband, that's a wife, that's a mother, whoever their significant other is. We want to make sure that we're doing this education with their people because they're going to need help, okay? And the more you can bring in their people, the better care your patient's going to get when they go home. It's important that we're monitoring bonding, and we already kind of talked about that in the maternal role attachment. That's how come we want to watch that, because if the patient's not attaching to their newborn the way that they're, quote, supposed to, that's a red flag for any of these conditions here we're talking about, all right? If the feelings persist, I always talk about baby blues. This is a really good topic for you guys to do your teaching presentation on because it's experienced by so many people. You want to guide most of your teaching, since it's the most common is baby blues, guide most of your teaching around baby blues, with the caveat that if feelings persist past the 10-day mark or whatever it is, let somebody know. If it gets worse, let somebody know. Again, letting them know when to escalate it is going to help them. Make sure, I already talked about safety, right? So make sure everybody is safe. Sleep when the baby sleeps. They can certainly seek counseling. Now, there are some cultures and some individuals who really don't believe in that, but we can offer it. And there are certain medications that your patient can take to help with postpartum depression and such. This concludes our content for postpartum.